Welcome, everyone. Thank you so much for being here. We are here today to talk about navigating autism in child welfare. And so I'm going to start off this presentation. I'm Jessica Greil-Burkhart. As it was shared, I'm an assistant teaching professor at FSU College of Social Work. I'm a licensed clinical social worker. And I also have studied, I have another degree in curriculum and instruction with an autism specialty. So that's been one of my areas of interest over the years. And so today I will be going over the first two objectives of our presentation, defining key features and early signs of autism spectrum disorder, and then explaining why early intervention is critical for long-term outcomes. And then I'll pass it over to Kristy. Kristy, if you just want to give an introduction and give your overview of objectives.
Yes, absolutely. So first, I apologize. My camera is on the fritz, so but I'm here. My name is Kristy Anderson. I am an assistant professor in the College of Social Work. And really what I do a lot of is large secondary data analyses focused on service systems for autistic youth and adults. So today I really am going to kind of present some preliminary findings using linked child welfare Medicaid data here in the state of Florida, and kind of help listeners understand risk factors for child welfare involvement among autistic youth, try to understand what their experiences are once they enter the child welfare system in terms of outcomes and placement patterns, and then ideally provide just a quick overview and some tips and resources for child welfare workers and other professionals who might engage with autistic children in the child welfare system.
And so something that you may notice during our presentation, we may be switching from identity first language and person first language. So identity first, you might hear us refer to as an autistic individual or autistic person. And then at other times you may hear us say person first, so an individual with autism. And that's going based on the autistic community. Typically it's their preference, which way they like to be referred. So for the purpose of us, we sometimes switch back and forth. But when you're working with individuals with autism, it's important to check with them what their preference is, whether they're wanting that identity first, autistic individual, or person first individual with autism. Okay, so we'll get started with the foundations of autism spectrum disorder. And so really, first, what is autism? What we know about autism is it's a complex neurodevelopmental condition that really impacts communication and behaviors. Typical onset for autism is in early childhood. And so what we'll see later in this presentation is that a lot of symptoms of autism often appear within the first 2 years of life. So we can make early diagnoses based on what we're seeing in impairments in communication and behavior pretty early. Now, the course of autism is lifelong. So an individual with autism is going to have those symptoms throughout their life, but they may vary over time. They may change in severity and impact as an individual progresses through their lifespan. And it's estimated that 1 in 36 children have been identified with having autism spectrum disorder. Now, we say it's a spectrum disorder. It's right there in the title. Because really what that means is that autism looks different for each person. So there are certain set of criteria that individuals must show to have autism, but how that criteria presents for an individual can vary in severity and intensity. It can vary in frequency, so it can look a lot different. So we know that there's this broad range of varying symptoms for an autistic individual. So we use the spectrum approach. More recently, there's been talk of autism is more of a wheel and not necessarily a spectrum, but a wheel of different levels of severity and impacts in those communication and behavioral realms. And before we get into those, just to bust some myth, there is a common misconception that autism equates to low intelligence, which is absolutely not true. Their intelligence and autism are two separate things. Now, because autism is a spectrum disorder, and because there might be some higher comorbidities, there might be some individuals with autism that also have some sort of intellectual disability. However, just having autism does not mean an individual is not smart, intelligent, is not capable. Autism also does not equate to violence. In fact, the majority of autistic individuals are not violent. And if they do display some sort of violence, it's normally inflicted on themselves. Part of the stimming can become harmful to themselves, or the violence is in response to the difficulties and the frustration that comes with trying to communicate and not having your way of communication be understood. So if there is violence, it is really for those reasons. Autistic individuals are not rude either. You heard in the video that sometimes individuals with autism have a hard time expressing emotions, but that does not mean that they do not have emotions and that they don't care. Just the way that they present and express is different than how non-autistic individuals do. Similar, put up a few of these other ones. So autism does not mean individuals are incapable, they're indifferent, and autism is not something to fix. And that was something that was very much stressed in the video. Individuals with autism think and interact differently, and that's not a deficit. It's just, as the powerful quote was said in that video, the world is not created for autistic individuals to be successful. And hopefully with more treatment and more awareness, we can shift our society to allow for autistic individuals to be able to function in the ways that they want to without having to mask their symptoms. But it's absolutely not something to fix. It's not a deficit. A few other things. As you heard, autistic individuals do feel emotions. Autistic individuals can, and they do, form a variety of meaningful relationships, friendships, family relationships, also sexual relationships, professional relationships. All of those are possible, and autistic individuals do have a variety of those relationships. Autistic individuals can have success in college, post-secondary education, and employment. And then vaccines do not cause autism, as well as what they call refrigerator parents. So there was a long time ago this idea that parenting techniques and maybe a cold parent or someone that didn't show as much affection in obvious ways to their children was the reason for autism. And both of those have been debunked, that they're not the cause of autism. With that, what causes autism, we don't fully know. The cause is not fully known, but it is unlikely that there's a single cause. We do know that there's a combination of genetic and environmental factors that contribute to the development of autism. So there's still research being done, and particularly with risk factors, we have identified quite a few, but there is still more that needs to be done in that realm. But what we do know with risk factors is that boys are 4 times more likely to develop autism spectrum disorder, and an individual, it's a higher likelihood of autism spectrum disorder if they have a sibling that also has ASD. If they're born to older parents, certain complications during pregnancy and at birth as well, and then certain genetic and chromosomal conditions like tuberculosis, Rett syndrome, or Fragile X syndrome. So difficulty or issues with the X chromosome in development and conception do increase the risk of an individual having autism. When we think about autism, how we understand it is through the Diagnostic and Statistical Manual, Edition 5, which is a big book of reference that healthcare professionals use to diagnose different mental health and intellectual behavioral concerns. And so with autism, the current criteria is for an individual to be diagnosed with autism, they have persistent deficits in social communication and interaction across multiple contexts. So they have difficulties communicating socially, kind of in back and forth conversations, communicating verbally and non-verbally, and developing, maintaining, and understanding relationships. And we see those across contexts. So in their personal life, at school, at work, in their family, in all these different areas, we see those deficits can persist. The next criteria is restricted and repetitive patterns of behavior, interests, or activities with at least two of the following. And so one, you heard, the individual in the TED Talk had strong interest in video games. And so oftentimes we see individuals with autism have highly restricted or really fixated interests that are abnormal in intensity or focus. We also see oftentimes insistence on sameness or difficulties when there's changes in their routines or their everyday patterns. Sometimes we see stereotyped or repetitive motor movements, use of object and speech, and then also either hyper or hypoactive responses to sensory input, like those loud noises that you heard from the video. And so with that, symptoms must be present in early development period. So for someone to have autism, the symptoms emerge in that early, 0 to 5 years of age range. They may not fully manifest until later, or an individual may not be diagnosed until they're later, even into adulthood. But we have to have that history of having these symptoms present in the early developmental period. They also must cause clinically significant impairment in social, occupational, and other important areas of current functioning, and they're not better explained by intellectual disability or developmental delays. So if we break this criteria down even further, thinking about social communication and interactions, for an autistic individual, what we might see is their use of communication is primarily focused on communicating their needs and their preferences, or to let you know that something's not right. So they don't really communicate related to sharing of interests or like getting to know someone. They may want to be interested and have those relationships, but how their communication functions is to ensure their needs are met. And so we may see limited sharing of interests with others, lack of eye contact, difficulty understanding the emotions and thoughts of other people, and a hard time with that back and forth reciprocal communication. We may also see limited nonverbal communication gestures like hand motions, pointing, some of those nonverbal ways that we communicate in everyday conversations. So with that, there is often difficulty forming and maintaining friendships. Again, it's possible, and many autistic individuals have very meaningful relationships, but it is more difficult for those individuals. And then when it comes to language, we see autistic individuals may acquire speech, the ability to talk, later in life, or not at all. We do have autistic individuals that don't communicate verbally, and they have other methods of communicating. And then we have others that speech has no impairment whatsoever. So that highlights just that idea of autism is on a spectrum with varying deficits and abilities. When someone's speaking, they're often very literal and concrete. And so they have difficulties with figurative language or inferential language, kind of imaginative language. And then we often see echoing, where individuals repeat back what they hear, they memorize what they hear. And so in a young age, if a caregiver is saying certain words, we often see them repeating that back at a higher rate and higher frequency than individuals without autism. When it comes to the other criteria, restricted interests and repetitive behaviors. So one of the key pieces of this criteria is really autistic individuals struggle with change and almost this kind of inflexible or rigid pattern of change or response to change. Now, none of us like change, right? It's always difficult, but for autistic individuals, any change in their routine, their day-to-day routine, or something that is different in their environment causes a lot more stress because of the way that their brain processes information. It's slower to respond to those changes. And so individuals can become more upset, may engage in more of that stimming behavior that you heard about in the video as a way to process those changes. Individuals with autism can also become overly focused on a specific interest or subject matter. And they often display a need for order. So you might see children lining their toys up, and then if one gets knocked over or out of place, they may become very upset that it's out of order, and they'll have to work quickly to get everything back in order. We may also hear repetitive questions. So even after they've gotten a response, sometimes individuals with autism will continue to repeat those questions. And again, that relates back to how they process information and receive information. And then a big one in this criteria is difficulty self-regulating. And I think the video described this very well, that he experiences extremes. He either expresses emotions and experiences emotions in very high, what many people would consider over the top ways, or he's very neutral to them and doesn't experience them in the same way that others do. So there's sensory hypersensitivity, which is when individuals have difficulties hearing loud noises or multiple noises, maybe multiple people talking at a time. And they might experience then those meltdowns that you see where maybe they completely shut down or they start to scream. You may hear people cover their ears, maybe rock back and forth, or respond in a way. They may start to cry. They may, go to their rooms or leave the situation because all of this sensory information coming in just gets too overwhelming. And then there's sensory hyposensitivity, which is limited reaction to stimuli. So individuals with autism may experience pain differently, to where something that may seem painful to someone without autism, like a paper cut, that individual with autism may not recognize that pain and may not respond to it. And so we're wondering, why are they not crying from this paper cut? But to them, they don't process that pain in the same way. Similar with temperature, colder temperature is often individuals have limited reactions to those temperature. We might see motor skills or personal boundaries. So sometimes individuals with autism may get very close to an individual, almost in their face, and start talking to them. And that relates back to that sensory hyposensitivity. They don't recognize the sensations and the stimuli that come on and the feelings when someone is that close to you. So with this, we often then see autistic individuals engage in sensory seeking behaviors, where they look for ways to experience different sensations. And then we also see the stereotypical movements in response to sensory stimuli. So that's what that stimming is. Common forms of stimming, which is essentially how they process emotions and experience them. We might see hand flapping or rocking back and forth. We might see spinning around or making certain noises that almost seem like ticks. And then stimming at times can actually become harmful. Sometimes we may see headbutting, where they bang their head against the wall or a table repeatedly. They may bite their arm or parts of their body, which is done for the purpose of regulating their emotions and the feelings that are coming with this sensory overload, but we know that it can cause significant harm to the individual. And so just to kind of make sense a little bit more of autism, there are three prominent theories that help try to make sense of how an individual with autism experiences the world and where some of these difficulties come from. So one of the primary theories is just executive functioning, that individuals with autism have a different way that their executive functioning in their brain works. And so executive functioning really controls our cognitive flexibility, our working memory, our ability to problem solve and self-regulate. And so with autistic individuals, when they have a different way that their executive functioning works in their brain, that's where we see the difficulties coping with change, or that insistence with sameness, difficulties maybe recalling memory, difficulties regulating their emotions. So we see those stimming behaviors. Another theory is the weak central coherence. So it is theorized that individuals with autism have a more difficult time seeing the big picture of a situation and integrating different pieces of a situation into that big picture. So that's why we often see that very literal response, or that's why it is sometimes harder for individuals to display empathy, because they're able to see all the parts of the situation, but not integrate it into one big picture to make sense of it. And then the last theory is the theory of mind, which is this idea that individuals with autism have a more difficult time being able to understand the mental state. So the thoughts, the beliefs, the feelings of other people. And that then makes it hard to engage in that reciprocal communication. So with autism, there are common co-occurring conditions that come with autism. So it's not uncommon for individuals with autism to also have attention deficit hyperactivity disorder, or have seizures, sleep concerns, gastrointestinal issues, anxiety, depression, obsessive compulsive disorder, intellectual disabilities, and eating disorders. So we talked about what causes autism and some of the early signs of autism. We can detect signs of autism starting from birth, really. And so we may see limited babbling in a baby, or not responding or making eye contact when you say their names. They may have a low desire to explore new things. And we know babies and toddlers want to get into everything. And so when we're not seeing them explore their environment and try out, different tools, that could be a sign that autism is present. We may also see delays in developmental milestones. We may see that they don't enjoy cuddling, or they're not making eye contact. They're not smiling or sharing enjoyment or interest as much. And so early signs are crucial, because that then gives us insight into a potential concern that we can then use an early intervention for. And so when we talk about early intervention, what we mean are services that are in place to help babies and toddlers and their caregivers learn the skills that typically develop during the first years of life on a variety of skills. So physical, cognitive, communication, social, emotional. And early interventions is actually part of the Individuals with Disabilities Education Act, so IDEA. Part C, which is a program for infants and toddlers with disabilities, states that there are federal grant programs that assist states in comprehensive early intervention programs for ages 0 to 3. And so why is early intervention important? Really, this quote summarizes it best. Early intervention has the power to transform the lives of autistic children and their families. So what we know is that brain neuroplasticity, I can never say that right, is highest when an individual is 0 to 5 years of age. And so what that means is that treatments have a higher chance of being effective long-term, because they are able to learn and process information that will then stick throughout their lifehood, their life course. And so when we intervene early within those 0 to 3 years, individuals are more likely to experience positive outcomes throughout their life in a variety of ways. More meaningful relationships, more success academically, have greater resilience overall. And so part of IDEAs does mean screening for autism and other developmental delays. So the American Association of Pediatrics recommends that all children be screened for developmental delays during regular doctor periods, so at the 9-month, 18-month, and 30-month intervals, but then specifically for autism at 18 months and 24 months. It's also recommended that if a caregiver or another professional has any concerns and they recognize any of those early warning signs, that they schedule an evaluation and seek additional screenings if it's detected that there is autism. And so there's so there's lots of common screenings that can be used when individuals, just in general, to detect developmental concerns, but also specific for autism. And these screeners help identify concerns in the realms of communication, in language, in motor skills, problem solving, social skills, academic abilities, and mental health. Some of the common ones are listed below. And I believe there is another workshop as part of the series next week that is really going to dive into diagnosing autism. So you're going to learn all about that if you attend that. So we're not going to go over too much of the diagnostic criteria. But from the screenings, if an individual is, once they're screened, if the screening shows that there are markers or risk factors for autism, then a referral for further assessment and evaluation is done. And so that is then done by a licensed professional or sometimes multiple professionals working as a team. And they complete diagnostic interviews with the children and the caregivers. They have specific diagnostic tools related for autism to really assess the specific criteria for autism. They engage in observation of the child in multiple environments, and then they also lean on collateral information when available. And so it's a very comprehensive process to diagnose autism. And then from that diagnosis, appropriate referrals can then be made. And so when we say referrals, early intervention programs can provide a lot of services. So they have health services and medical services, nutritional concerns, because sometimes autistic individuals don't respond well to certain textures of food. And so they may be lacking in maybe vegetables or fruits or protein because of those responses to different textures. So with early intervention, they can get set up with nutritional services to help them grow and thrive. Occupational and physical therapy, speech therapy, mental health treatment, transportation, visual services, and special instruction all kind of fall under that blanket of early intervention. Thinking from a clinical standpoint, when we're working with individuals with autism, really the focus is on helping the child reach their full potential and being successful in life. So it really focuses on empowering the client to live their life in a way that's helpful for them, that they can succeed. Treatment is not about conformity, compliance, or control. And so we can utilize a lot of approaches. Applied behavioral analysis, ABA, is a common one, as well as social skills training, cognitive behavioral therapy, and then also parent training and support to really help the parents and ensure that they have the resources and support that they need to best work and help their children. Okay, and so now I'm going to pass it over to Kristy, and because of technical issues, we're going to do a quick swap of seats here.
Oh, no, it's fine. Hi. Yes, okay. Can everyone hear and see me? Okay, I assume my computer went on the fritz, but I want to thank Jessica. That was a good overview of autism and talked about the importance of early intervention. So again, a lot of what I want to focus on today is just kind of going over, well, what do we know about autistic youth who are in the child welfare system? So now that we have like a broad understanding of what autism is and like its characteristics and its presentation, like why should we focus on this subpopulation within the context of the child welfare system? Well, there's really 4 kind of major components. There's a high prevalence of autism among children in child welfare. Autistic children have elevated risk of maltreatment. Complex support needs and the co-occurring mental health challenges that Jessica discussed kind of exacerbate and really shape the types of experiences that autistic youth have in the child welfare system. And we also know from preliminary research and just anecdotal evidence that a lot of child welfare workers and professionals feel like they need more autism specific training, especially given the high prevalence in the general population, as well as the population of autistic youth in child welfare. So nationally, the estimates kind of vary, but the estimates are that 6 to 15% of autistic children in the United States are involved in some kind of child welfare investigation. 12% of those with autism and 18% of those with autism and intellectual disability, which was formerly mental retardation, are placed in foster care versus 10% without. So we know there's also a higher risk for out-of-home placement. A lot of the data I'm going to present today, or kind of walk you through, are Florida-specific estimates. And it's based on a sample of 624,000 children in the state of Florida who had a record of Child Protective Service involvement and also had Medicaid between 2016 to 2021. So it's not a complete census population of all autistic youth in the child welfare system in Florida, but it's probably representative up to maybe 85%. So if we're thinking about the Florida population, these are pretty close estimates. So among those children, we know that about 3.5% or 21,973 recorded maltreatment reports in the state of Florida were based on children who had autism. So again, focusing on this idea of, well, why is the autistic subgroup important? Well, we know that autistic youth, like I said, face higher rates of maltreatment compared to youth with no autism. This is especially true for physical abuse. So if you notice here, for the second graph, again, this is a comprehensive sample of children in the state of Florida who have autism and also Medicaid. 25% of autistic youth had a maltreatment report focused on physical abuse versus 15% of youth without. Emotional abuse was slightly higher, as was neglect, and sexual abuse is pretty comparable. We also know that autistic youth are also more likely to have multiple maltreatment reports. So as you can see from here, 54% of autistic youth had just one report within the time frame 2016 to 2021 versus 60. And then 14% had 4 or more maltreatment reports versus the 10% of youth without. So it is slightly higher. Despite having the high rates of maltreatment reports among autistic youth, we also know that substantiation rates are significantly lower. So about 8% of maltreatment reports for the autistic adolescents in Florida are substantiated. And there's a lot of reasons for low substantiation rates. One might be that behaviors can be misread as abuse or neglect. So like self-injury, the meltdowns or hygiene issues, they may be mistaken for maltreatment. And the mandated reporters may file like just in case referrals due to this uncertainty because they don't know what to attribute to maltreatment versus what to attribute to the autism characteristics. The communication barriers experienced by a lot of autistic youth can also complicate investigations. Autistic children may struggle with traditional interviews, especially if feeling overwhelmed or are nonverbal or don't use words to communicate. So that makes it harder for professionals to kind of confirm abuse through disclosure. And then again, kind of speaking to this idea of the lack of informed autism-specific training. So professionals may not know what autism characteristics to look for when they're starting to investigate abuse. We know that school and child care providers are key referral sources. So just like youth without autism, most of the referrals for maltreatment or child welfare involvement are coming from either education systems or legal and law enforcement, about 26% versus 23% comparably. But medical personnel and social service personnel comprise of less than 10% each. So that also might come from this idea of autism-specific training that's required. Co-occurring youth with disability, like those who have intellectual disabilities with autism, also can contribute to the high rates of maltreatment and low substantiation. So we know that intellectual disability is prevalent in about 40% of autistic youth in the United States. And intellectual disability is really based on IQ, so an IQ of 70 or under. It can include a wide range of disabilities, including like Down syndrome, cerebral palsy sometimes has co-occurring intellectual disability. It's kind of like this myriad of diagnostic intersections. But what we do know is that autistic adolescents who have ID or intellectual disability experience their first maltreatment report later. So 44% of youth with autism and ID, the orange line here, have their first maltreatment report in adolescence, 13 to 17 years, versus 22% of youth without disabilities, 18% of youth who only have autism, and 36% with intellectual disability. So they're entering the child welfare system later. We also know that they are more likely to be removed from the home, 18% versus 10% of children without disabilities. So it's almost double. And they experience longer durations in out-of-home placements. 54% of youth with autism and ID stay in out-of-home placements for 5 years or longer. And then it's followed by those with ID only, autism only, and then the no disability population of 26%. So regardless of whether you have autism or intellectual disability or both, you're at higher risk for staying in out-of-home placements longer. Risk factors for CPS involvement and out-of-home placements really coincide with the risk factors and the challenges dealing with substantiation that we see. So common is the challenging behaviors like aggression, self-injury can increase the risk for child welfare involvement. We also know that caregivers of adolescents with autism experience higher stress. They have higher entry of psychiatric needs and burnout and caregiver burden. They often experience lower family social support or isolation. They're more susceptible to poverty and material hardship, which we know are risk factors for maltreatment and CPS involvement. We know that parents of youth with autism are more likely to cite disability as a reason for removal. So when you think about the high expenditures and the high caregiving demands that kind of coincide with having a child with autism, you might have more voluntary, I guess, involvement with child welfare among parents. We also know that demographic factors can impact it. So risk factors like age, sex, and race can also facilitate or promote more child welfare involvement. And I want to just highlight here very quickly that these risk factors that contribute to child welfare involvement, again, focus on the Florida sample, will show that youth with autism or intellectual disability kind of experience slightly higher rates. So 56% cite disability as a reason for removal versus 34% of youth with autism only and 42% with ID. So again, that co-occurring intellectual disability is a really strong impact factor in terms of voluntary removals. Okay. We also know that there's higher rates of neglect, inadequate housing, abandonment, and caregiver inability to cope, regardless of disability type, relative to those without. We also know in terms of placement type. So once a child has a maltreatment report, it's substantiated. We know that they are more likely than children without autism to be placed in kinship care, less likely than children without autism to be placed in kinship care. So in Florida, about 28% of autistic youth are in kinship care versus 60% or 59% of youth without autism. And then conversely, about 1 in 4 autistic children are placed in congregate care. And of those, 70% of them have co-occurring ID. So higher rates of congregate care, lower rates of kinship care once they're placed out of the parental home. In terms of placement outcomes, about 76% of children without disabilities exit custody versus 69% with autism only and 53% with autism and ID. So having autism and then having autism and co-occurring ID again in particular lowers your risk that lowers likelihood that you're gonna exit custody. Among those who do exit custody, a little over half of children with only autism or autism and ID are reunified. 30% had adoption with autism, 23% co-occurring. Guardianship ranged from 19% to 12%, and then the lowest rate, 4% of youth with autism only aged out, and then 15% of autism and ID. So again, regardless, it's kind of focusing on there's two major takeaways, that the autistic subgroup are more at risk for poor placement outcomes, and then elevated risk comes among that subset of autistic youth with co-occurring ID. So what can we do as child welfare workers or professionals in general? Well, there's a lot within our control. So first, we can support families earlier, connect with them to respite care, coaching, behavioral services before a crisis occurs, to really recognize that family risk factors can help. If we address family risk factors, we're essentially going to remove the risk of having voluntary removals from the home. When children enter care, we should be asking questions about their unique needs. So how they communicate, how they handle the stress, what their triggers the stress, how do they regulate sensory input. Stable placements are critical, especially in family-based settings. So we need to work across the systems, education, developmental disability services, healthcare, to coordinate care, especially given that wide range of referral sources that we see within the autistic population. And most importantly, we must commit to building a system that recognizes and values neurodiversity. So not necessarily viewing autism as a problem to fix, but more as a difference to support. And I also do want to point out that there is a neurodiversity informed policy and training that's offered through FSU's Institute for Trauma and Resilience Studies. So I did include the link here for those of you who might be interested. And that's basically my overview. So Jessica and I are ready to take questions. So how much longer is an autistic child stay in foster care versus an adolescent more generally? Oh, I see. Okay. So, I don't have the estimates at the top of my head. Let me go, if I go back to the PowerPoint slide, let's see. The data that I have on hand is only disaggregated by autism and intellectual disability, but of youth without disabilities, it's 26% 5 or more. I haven't broken down the average means. I do have that data in a manuscript that's under review that I'm happy to send you that talks about average length of stay. It's also important to note though, like in this specific data, it's across the lifetime, but some of the data sets, it's ongoing. So we don't know when they exit. So that's why I had to kind of cap it at 5+ years. So I don't know if that answers your questions.
Thank you so much for both of you today. Just want to give you a huge round of applause.
Thank you so much. And I'm available if you need to contact for any further questions.